So hello, good morning everybody. My name's Amaia Calderón, and it is my pleasure to introduce you to the first keynote speaker of today's symposium. So his name is Dr. Gauden Galea, and he was the director of the Division of Non-Communicable Diseases for the WHO Regional European Office. Unfortunately, he could not be here today because he has been recently appointed the WHO representative for China, but he kindly sent us his presentation that we will play for the following minutes and that we hope that you enjoy.
Good morning, and thank you for inviting me to speak at this symposium on multimorbidity. As the introduction probably has already told you, I am in transition and have just taken up my post as WHO representative in China. I'm grateful to the organizers for still keeping me on the program. I hope to give you a presentation about some work we have done during my tenure in the last 7 years in Europe, linking the work on multimorbidity that you will be discussing to our thinking and findings on a multi-year project on health systems. Indeed, I will go from mortality through risk factors to multimorbidity to some findings on health systems in the hope of setting the context for the discussions that you are holding in this symposium. Our context in the World Health Organization and indeed in the UN in general is the Sustainable Development Goals and specifically the goal number 3, which deals with health and well-being. Within the non-communicable diseases, the field, we have had a lot of success in incorporating targets and risk factors related to NCDs within the Sustainable Development Goals. They had been, non-communicable diseases had been ignored within the Millennium Development Goal era and had been regarded as not being an issue for poor countries or an issue for development. We have now come of age, but the challenge is for us in the Secretariat and in member states to identify what needs to be done in order to achieve those targets, focusing mainly on the reduction of mortality and the risk factors that lead to early death from non-communicable diseases. Within Europe, we are working to the overall program of Health 2020 and multiple action plans and frameworks, including one overall action plan for the prevention and control of NCDs in the WHO European region. In setting the context, it is useful to look at the pattern of mortality from non-communicable disease. And in this slide, I focus, and in this family of slides, I focus on circulatory diseases, deaths from circulatory diseases occurring among men in European countries, and looking at them across the whole region. This is what I call the spaghetti graph of mortality, going back as far as the Health for All data takes us to 1970. Not much to discern here, apart from a lot of variability, but if we color the countries by 3 groupings, select some of the 53 and color them into the countries of the former Soviet Union, the CIS countries in red. In blue, at the bottom, the countries of the EU 15, the old members of the European Union, and in between the green countries, the countries that joined the EU after 2004. And here already you can see like an archaeology, a strata of mortality, the rapidly declining and historically declining EU 15, the countries in the middle of the EU 13, and the former Soviet Union trailing behind, but already catching up in the last 10 years. Indeed, if we want to summarize the experience of these three regions, we group them here by average, and the three patterns emerge very clearly. Much has been said about the spike in mortality of post-1990, but the most important for us here is to focus on the last part of these three trends. And here, all the countries of Europe are declining. Indeed, the countries that have the highest premature mortality are the ones that are declining the fastest. I do a thought experiment. I transpose the two graphs for the EU13 and the CIS countries as far back as they will go, so that visually they give us a suggestion of a continuous curve. Think of it as a thought experiment of how a natural trajectory of decline would look like, and gives us an idea of how long it would take for the CIS and the EU13 to catch up with the premature mortality burden that we are seeing in the EU15. And indeed, despite the fact that we have only 1 decade left until we have to report on progress towards the Sustainable Development Goals, we can see how far behind, despite the rapid progress, how far behind some countries are from the forerunners. And indeed, at current rates, if this curve has any meaning in reality, we would see a decline that would take us as much as 60 years, 6 decades, until we get to the levels that we are enjoying in Western Europe. But our hypothesis is that the evidence that we have today and the experience that we have today is much stronger than what the Western Europe had in the 1970s. Any one of us who has been working for any length of time knows that in the 70s, even things that are well established like today, the impact of taxation on tobacco consumption, in those days were hotly disputed. So there is a sense that we can leapfrog and accelerate the improvement, applying the evidence of today to the mortality rates that we saw in Western Europe in the 70s and 80s. Indeed, our thinking on this has been captured in a special issue of EuroHealth. The link to it is on the slide, and you may read more about our observations and speculations on the possibility of leapfrogging within health systems in order to achieve an acceleration in the countries of greatest burden. And indeed, acceleration is needed because even though decline is happening, some of the preconditions are not improving at all. And I switch here from mortality to treatment and to risk factors, and I present on the slide the 9 voluntary targets of the Global Monitoring Framework on Non-Communicable Diseases. At the current projections, you can see that we seem to be on track for achieving the target for premature mortality and the control of hypertension, but all the others are endangered: physical activity, salt, risk management for cardiovascular disease, and availability of essential treatments, or unlikely to be achieved at current rates: alcohol, tobacco, and overweight and obesity. The point, though, is that if we continue on track as we are, we could overcome excess cardiovascular, even non-communicable mortality in a decade. But if that were the case, how to prepare for the next challenge? It's not just the achievement of the Sustainable Development Goals that we have before us, but the changing demography, the changing patterns of morbidity, and how to respond to the changing structure of non-communicable diseases in the populations of Europe and the world. A couple of slides from Clalit Research Institute in Tel Aviv illustrate the point that even today, the pattern of risk and morbidity is not just a simple single risk factor or single disease. Indeed, this area graph gives the relative distribution over age for a number of risk factors for non-communicable diseases. And we can see that by the age of 45, 40% of the population already have one risk factor, and on average add another risk factor with every decade. Multiple risk exposures, therefore, are the rule. This is a similar graph, but this time from the same source, but at the same time now showing the number of chronic conditions by age, and the black bar running horizontally gives us the 50% mark, and we can see that by the age of 45, people already have the first chronic condition and add on average another chronic condition with every decade of life. These two slides suggest that while we do have some utility from risk factors targeting individual risk factors, from targets on individual risk factors or individual diseases, the reality that we face in health systems is of multiple risk exposures and multiple chronic conditions. In response to that, since 2011, we have been working on a series of assessments for looking at the challenges and opportunities for health systems in addressing chronic non-communicable diseases. The type is, I am certain, too small for you to read, but basically this gives us a timeline of a series of activities that were carried out to develop a tool, to validate it, to run assessments in a number of countries, and to compile the lessons from these assessments, culminating in April of 2018 in a conference in Spain that reviewed all the results. This is just an illustration of the multiple assessments that were carried out in the countries and the assessment guide. All these reports being available on the internet for those who are interested in downloading and looking at individual countries. Out of these studies, some general lessons can be drawn that are very pertinent to the discussion of multimorbidity. In today's world of chronic diseases, health services need to be people-centered. People need to be equal partners and have their services centered around their needs, not the diseases that they suffer from. Services need to be comprehensive, not just clinical, but also social, also environmental, and need to involve a large number of aligned services, not specific silos offered separately for each of the conditions. Health providers need to be trained in the provision of such comprehensive aligned services. Health financing must be adequate and include intersectoral services that go across health and social services, for example, include rehabilitation and labor and workforce related financing. So it is not just financing for specific health services. Information solutions are essential components of modern treatment, not just in the provision of more personalized treatment, but even more importantly in the data mining, in the application of machine learning, artificial intelligence, to improvement of efficiency, to the identification of new target groups, and innovation within the health system for people who suffer from multiple chronic conditions. And a multi-pronged medicines policy that, yes, provides removes financial barriers to the core non-communicable diseases that are drugs for core non-communicable diseases that are needed by these people. At the same time, realizing that NCDs are not just for major non-communicable diseases, but now include a wide gamut of conditions, from musculoskeletal to mental to the classic non-communicable diseases. And that finally, our health system is not just there to be strengthened and in order to deliver services more efficiently, but that it should be governed and monitored and held accountable for the improvements in function and the reduction, both social and physical, as well as the reduction in mortality. That outcomes must be part of our accountability. As I take these lessons from Europe and from the country assessments that we have conducted, I am humbled by the fact that now I am serving in a 1.4 billion population country where massive changes of a realization of similar challenges is very much present, and a country that is undergoing rapid change. In March, the government of China has been restructured. There is the setting up of a new state medical insurance administration. Everywhere you look, big data is on the cards, and the State Council has even issued guidelines on the internet plus healthcare. There is a constant realization of the burden of non-communicable disease, the reality of morbidity and multimorbidity, and the whole range of issues that we have learned from the European experience are being again experienced in this country over a much shorter time period. As I thank my co-authors on this presentation and the contributors of much of the material and the lessons of the past studies in the last 6 or 7 years of project, I also take the opportunity to thank you for allowing me to make this remote presentation. And I look forward to the results of your symposium, hoping that I can reciprocally draw lessons that I can apply in my new context. So despite the absence, my interest is very much in your work, and I thank you again for your attention.